Fantastic. Before we show this video, I just want to acknowledge the owners of the lands from which we all come, their elders past and present. I also want to acknowledge the medicine keepers, the light keepers, the people who've brought these medicines forward throughout the ages, from the beginning of human civilization to today. These incredible sacraments that help us to see ourselves more clearly and connect with others and our planet. So with that, Ilan, if you could please show just the short, the CPAT video to give everyone a flavour of our new little short while a few others are still jumping on, and then we'll commence with the slides. Thank you, Ilan.
Medicine Institute proudly presents the Certificate in Psychedelic-Assisted Therapies. This innovative course has been developed to meet the anticipated demand for trained therapists to provide psychedelic-assisted therapies for the treatment of mental illness in Australia.
That MDMA could be important for the future of psychiatry as the discovery of antibiotics was.
Graduates of this course will also have opportunities to participate in research trials in Australia. This highly acclaimed course features a world-class faculty, including Professor David Nutt, Dr Rick Doblin, Dr Gabor Mate, and many of the leaders in the field.
So the plants don't give us the truth, the plant help us manifest and see the truth.
This course will provide medical and health professionals from a range of disciplines with the key attributes needed to become a psychedelic-assisted therapist. You will learn history, pharmacology, a working knowledge of state and stage change theory and technique, screening and integration processes, and gain practical experience of working with people in non-ordinary states.
It's time to say there should be no limits to the therapeutic research we do with these drugs.
The course will give you enormous insights into the root cause of mental illness and the healing process, and contribute to the growing body of knowledge and expertise in the field.
If you're wondering about doing the course, I would highly encourage you to. It's very experiential. There's lots of, great lectures and things, but there's lots to actually sink your teeth into as well. And it's fabulous to go away a few times in the year and to be together with other like-minded professionals.
Humanity now is in a race between catastrophe and consciousness. The psychedelic renaissance is here to help consciousness triumph.
Don't miss your chance to be part of the new frontier in the treatment of mental illness. Apply now for your certificate in psychedelic-assisted therapies.
Now, the program itself has been so well articulated and so well presented by amazing practitioners, Nigel and Tra-ill, who are trailblazers in the field of psychedelic medicine in Australia.
And there you have it. Ali, if you want to pop the slides on, that would be fantastic. And
yeah, should be able to. Is that working?
Yes, if you can go back to the beginning, that'll be wonderful. Thank you. And we'll go to the next slide. Thank you. And the next one. So I think most of us on here will appreciate the mental health emergency that we're in at the moment, which is getting worse. Pre-COVID, 1 in 5 Australian adults with a mental illness, 1 in 8 on antidepressants, including 1 in 4 older Australians, and 1 in 30 children as young as 4. Just recently, research came out that suggested that 4 out of 5 Australians are now reporting poor mental health, with at least a third of Australians saying their mental health has declined significantly during the pandemic. We'll go to the next slide. Thank you, Ali. And of course, there are certain sectors in the population that are really struggling and have a far higher incidence of mental illness than the rest of the population, sadly, and that includes, of course, veterans and first responders. You can see, you know, the significant incidence of a range of mental illnesses and addiction that occur in these populations, but also in communities like farmers, accountants, lawyers, and so on as well. Next slide, thank you, Ali. It's coming up. And these terrible statistics, which make us only, well, the second worst in the world mental health statistics, only ahead of Iceland. And yet we have so much more sunshine. And of course, this mental illness leads to unemployment, it leads to homelessness, and tragically it leads to suicide. And the total cost of mental illness and suicide to the Australian economy last year was $220 billion, according to the Productivity Commission. Next slide, thank you, Ali. Oh, really weird with this delay today. The elephant in the room, the lack of innovation in treatments for mental illness. You can see there, the elephant's trying to get the attention of the bureaucrats, the government, you know, all sorts of other people. And we're talking a lot about new patient access gateways, new telehealth sessions, training more psychologists and psychiatrists and so on. But if we can't get to the root cause of people suffering, we actually can't get people well and out of the system. Next slide, thanks, Ali. Are we having a technical hitch tonight? There seems to be some.
It's working on this end, Tania.
Oh, it must just be me. I'm really sorry about this, everyone. I'm just in a technically difficult area, and that's what's causing me a whole lot of my problems. So there's been no improvement in treatment outcomes for the past 50 years. And in the case of depression, only 30 to 35% of sufferers experience remission from pharmacotherapy. And in the case of these antidepressants, of course, the side effects are really significant, very hard to withdraw from. In the case of post-traumatic stress disorder, remission rates are as low as 5%. Next slide, thank you, Ali. So more of the same is definitely not going to solve this problem. Next slide, thank you. So we're a charity, for those of you that don't know us. My husband and I, Peter Hunt, and I set up this charity 3 years ago to alleviate the suffering caused by mental illness in Australia and expand the treatment options available to practitioners like yourselves and your patients. The goal is to establish safe and effective psychedelic-assisted treatments. Our focus at the moment is on medicinal psilocybin and MDMA, but we're also interested in other psychedelic medicines. And for us, success means that these therapies become an integral part of our mental health system. So if you go to your doctor or psychiatrist, they will offer this as a first-line treatment, as well as the other options, with full disclosure on the risks and benefits of all kinds of treatment. That these medicines continue to achieve the incredibly high remission rates that they've been achieving in the trials. 60 to 80% remission rates after just 2 to 3 medicinal doses of the medicines with a short course of psychotherapy. And of course, our goal is that these medicines and treatments are available and accessible to all Australians, no matter their financial circumstances or their location. Next slide, thank you. And we will flick through this. This is our board, but this is all on our website, so I'm not going to go through this now. Next slide, thanks, Ali. Just flick through all these really fast. Just keep hitting the bottom. These are all the leaders in the field who are ambassadors, lots of psychiatrists, as you can see on our advisory panel. Keep going, Ali. Psychologists, GPs, physicians, pharmacologists, religious leaders, anthropologists, public health experts, and so on. Next slide, thank you. So the remarkable thing about these treatments is they only require 2 to 3 medicinal sessions in combination with a short course of psychotherapy, and that leads to a cure in 60 to 80% of cases, with trials with thousands of people now in this renaissance in this area. So these are not just palliative treatments. They're not just about managing symptoms. They are about getting people well and out of the system. They're very safe in medically controlled environments, non-addictive. Both have been granted breakthrough therapy designation by the FDA in the US. It's a very rare designation, only given to medicines that could be vastly superior to existing treatments to fast track the approval process. And MDMA is now in part 2 of phase 3 trials and is likely to become a prescribable medicine in the next 18 months. Next slide, thanks, Ellie. And that's over to you, Ellie.
Thanks, Tania. So I'm going to run through some things pretty quickly because we want to leave some time for discussion, and discussion's always more fun than just talking. So there's, you know, we could talk about this stuff for hours, but we won't. So what are psychedelics? Psychedelics were traditionally from nature. And if your organic chemistry is up to scratch, unlike mine, these names might mean something to you. Phenethylamines and tryptamines, there are sort of 2 chemical classes of psychedelics traditionally. Then there are also synthetic psychedelics. So LSD, famously discovered by Albert Hofmann, and which importantly has a serotonin-like structure, which we will discuss shortly. And of course, MDMA, which is, you know, people sort of debate whether it's a classic, you know, it's not necessarily a classic psychedelic, certainly has psychedelic properties, but it has other properties as well, which lead some people to label it as an entactogen or an empathogen because of its properties, which we'll talk about shortly. Now, when we talk about psychedelics, how they work, it's not the easiest thing to do, particularly in a short amount of time, but we're going to give it a go anyway. And I'm going to talk about the the theoretical basis of the purported mechanisms of action on a molecular level, a global network level, then the theory behind it, and then the phenomenological level. And this is one of the reasons I'm excited about psychedelics, because they really, I think, they join the mind and the brain. You know, there's we can tend to think in boxes, in one or the other, but really here we have everything wrapped up nicely, as we'll talk about now. So it appears that on a molecular level, all psychedelics exert their psychedelic influence through serotonin 2A receptors. So serotonin 2A receptors are necessary. They're G protein coupled receptors, and they're certainly necessary for the psychedelic action. Then MDMA does certainly trigger 5-HT2A receptors, but it also has these other interesting mechanisms of action which make it, you know, really sort of appropriate for particularly trauma work, because it has a few, you know, if you wanted to sort of design a treatment for trauma, you would want someone to be able to feel really, really safe, really quickly. You'd want someone to be able to sort of trust you. You'd want them to sort of be able to trigger their emotional centers so they can sort of work with the emotions and the trauma as it comes up, but at the same time feel sort of safe and relaxed enough to do that. And that's essentially what you get with MDMA, which is why it seems to be such a therapeutically effective medication to assist in therapy for psychedelics. So where are the serotonin 2A receptors? They're in a lot of places, but they're particularly densely populated in the cortex. So the outer parts or the newest parts phylogenetically of our brains. And it's theoretically, they stop inhibition. So in other words, what they do is they release networks of neurons that usually don't talk together or don't talk to each other, and they release the inhibition. So the sort of down regulation of networks that sort of keep us in loops. You know, so we all have, I guess, particular loops that we see the world through. We all, you know, see what we expect to see, and you know, a lot of that's from our past, you know, based on our past experiences. And particularly if you think about people who have all sorts of mental illnesses, you know, transdiagnostically, a very significant aspect of mental illness across mental illnesses are the sort of loops that we get ourselves stuck in, whether they're cognitive loops, emotional patterns, relationship patterns, behavioral patterns. And psychedelics seem to exert their influence, at least in part, by allowing the brain to get out of its usual structured, restricted network communications. So this is a pictorial example of, or this is from a study. This is a brain scan. It's obviously not a brain scan. It's a representation of a brain scan. And around the circumference of the circle, all the dots are neural networks. And in both circles, there are the same number of lines. So there's the same number of communications between different parts of our brains. But usually, you know, if you're human and you have any insight into yourself and other people, you realize that you see the same thing over and over again. But on psilocybin and psychedelics, what seems to happen is this usual downward influence from the cortex that sort of limits our ability to see things anew or to see things differently, and limit the ability of neural networks to talk to each other. That sort of downward inhibition is lost. And so you end up with a whole lot of neural networks talking to each other, which usually don't. There's been particular focus on the default mode network, which is the sort of, it's a resting state network. So it's, you know, like if you are asked to sort of not do anything, if you're anything like me, your mind will start, you know, going through all these crazy loops and anxieties. What do I have to do tomorrow? What did I do today? Did I feed the dog? And, you know, all that stuff is sort of thought to be the default mode network. And that in particular is disrupted during ingestion of psychedelic medicines. And that, you know, there have been sort of theories about how that could relate to, you know, to one's ego, or that sort of cognitive, very restrictive part of us that keeps us very much anxious and a little bit crazy. And this is the main theory behind psychedelics. And I'd really encourage people to look up this paper because there's too much to talk about in a few minutes. But this is based on the latest neuroscientific theories of global brain function by the gentleman with the glasses, who's called Carl Friston, who is the most influential neuroscientist around today. And fortunately for us, he's helping out with Mind Medicine Australia as well. And he's maybe a bit of a fan of ours, I hope. But he's helped us out and he's spoken with us. And his theory basically underlies this idea that usually the brain functions by reducing prediction errors or free energy, which basically translates to my brain sees what it expects to see. You know, none of our brains see reality. We all see what we expect to see based on our past experience. And particularly for those of you who work with traumatized individuals or have had trauma yourself, you will understand this very well, that our past really influences the way we have relationships, the way we have relationships with ourselves, how we see ourselves, how we see the world. And this is, you know, part of Carl Friston's theory. He's mapped it out mathematically and statistically. And the idea is that psychedelics disrupt this pattern. And again, this leads to the phenomenological understanding of how psychedelics work. And psychedelics seem to give people the experience of the following. People seem to be able to access unconscious and, you know, traumatic experiences which they haven't been able to in the past. There's an opening up of one's emotional world. There's an access to psychic conflict, love and hate and conflicts like that. There's the loss of that controlling sort of ego thought-driven part of ourselves, which seems to sort of lock us down into old patterns. There's increased mental flexibility. There's a sense of connectedness to the self and other people and the world. There's good old insight into oneself. And it's really about experiential learning. This is learning through the experience that one has in one's mind through therapy. I do want to just emphasize, because I haven't said it yet, this is, as Rick Doblin says, this is therapy. So the psychedelics don't heal people. It's therapy that heals people. It's just that psychedelics facilitate therapy. And so that's a really important thing to think about. It's a new paradigm. I'll just talk about this slide for a second. It's a new paradigm for mental health. This is not someone having medications for months or years or decades. It's someone having, well, here you can see the sort of layout that the research protocols have laid out for us. It's not the only way to do psychedelic therapy. Stan Groff, for example, developed psycholytic therapy, which was a more long-term psychotherapy with psychedelics. But currently, to fit it into a research paradigm, essentially what happens is that people with PTSD or any number of mental health issues will have preparatory sessions, which is basically about the set and the setting. It's about getting one into what the set, so the mental set, what am I going in with? Then there's the setting. It tends to be not a medicalized setting, so people might bring in things that are emotionally relevant to them. People might listen to music. People are often in a comfortable setting with two therapists. There are two therapists with the people in the experimental session. So then we have the experimental session. So there may be a few preparatory sessions. Then there's the experimental session, which is the experiential session, which lasts for many hours. It's typically a day. And that is when the person ingests the psychedelic. And it's really the psychedelic and the mind really lead the person. The therapists tend to be not particularly directive. It tends to be self-directive. And the therapists are there to make sure the person is safe. And then after the experimental session in the weeks to come, there are integration sessions, which is really what it's all about. It's about integrating whatever has come up for the person during the experimental session and during that sort of that increased neuroplasticity and new ways of seeing the self and the world is where all that's, and for people's traumas that came up. And it's really about integrating them like good old fashioned therapy. There have been a number of psychotherapeutic techniques, Tra-ill can speak more to this, that are used in integrative sessions, but it can basically just be good old fashioned therapy, just helping people try to integrate what came up for them. And that's why you get sort of patient testimonials like, I felt like I went through 15 years of psychological therapy in one night, which is how I actually got interested in psychedelics by watching the documentary of Trip of Compassion. And that's exactly what I saw. I do long-term therapy with people that have been traumatized and, have had a lot of difficulties in their life. And I can help people. It just takes me out 5 years of weekly therapy to really help people heal. And I saw, what I do in 5 years done in a month or two, which is difficult to believe until you actually see it. I think that it's going to hopefully refocus mental health. Mental health and psychiatry in particular often sort of sits uncomfortably between the mind and the brain. This is a sort of famous paper discussing that, that most psychiatry trainees read, if not all psychiatry trainees read. And it's about this sort of uncomfortable balance. And I think that, it's my impression anyway, that psychiatry has kind of lent on the brain a little bit too much, perhaps, over the last decade or so, and we've kind of forgotten about the person's subjective experience. And I think psychedelics are a great way to rebalance this. Psychedelics are interesting to neuroscientists as well as, psychoanalysts. So I hope that psychedelics will bring a new focus into mental health, which will be back on sort of the person's experience in their life and the childhood experiences and difficult experiences they've had. I'm just talking, Tania and Tra-ill, so I'll just talk until someone stops me and tells me not to talk anymore. So it's really important to be aware that these medications, when they're given in, this is obviously not, we're not talking about using this at raves, we're not talking about using this on the street, we're talking about using these as per the protocols which have been developed by MAPS and other organisations in, and that's ensuring that people are medically and psychiatrically cleared. That means administering medicinal grade medication. That means having safety equipment just in case. And when these medications are given in these types of contexts, they're actually extremely safe. All the research coming out is really positive in terms of side effect profile. They're really, really safe medications so far.
Fantastic. Tra-ill, were you going to add anything into this at the moment, or would you like us just to get to the Q&A so that we have a longer Q&A with you?
That's fine. Yeah, that's fine.
Are you sure?
Yeah, Ellie's doing a great job.
Well, we have so many wonderful people on this webinar as well. It's great to see. Look, I'll just mention briefly this particular chart. So Ellie just showed you the safety profile in clinical environments, but even in recreational environments, these medicines are considered extremely safe. We are not at all advocating for their use in recreational environments, but as you can see, this was a study that was done at the University of Melbourne in 2019 that compared the relative drug harms of different drugs as viewed by emergency practitioners, including psychiatrists in emergency units in hospitals and emergency physicians and so on. And alcohol, of course, they're by far the most dangerous drug to self and others. Down the other end of the scale, you see psilocybin and MDMA. So even in recreational environments, in their pure form, very safe, often adulterated, lead to poor outcomes. Next slide, Ellie. And of course, the effect size normally for an antidepressant is about D equals 0.3, but psilocybin for depression there you can see 2.0 to 3.1, and MDMA also off the chart. So these effect sizes are off the charts. Next slide, Ellie. And the other really remarkable thing about these treatments is the increasing remission rates over time. And as those of you who prescribe medicines or take medicines know, you may get an initial uplift, but then that may plateau, and then the practitioner or you're a practitioner, you'll be saying, we might have to change the medication or increase the dose. In this case, as the integration with the psychotherapist continues, patients will often have a persistent and increasing remission. And we see that in the next slide, Ellie, if you can click to that. And this is an interesting slide again on MDMA, and as Ellie spoke about, we're talking about pure GMP grade MDMA, which increases fear and defensiveness and ensures that a patient is not re-triggered or re-traumatized. You can see here in these MAPS phase 2 trial results, 105 participants, all with an average PTSD for 18 years. So that accounts for severe and significant suffering, with 52% of those patients going to remission immediately after 3 doses and 68% at the 12-month follow-up with further integration. So that again illustrates these increasing remissions. And we'll go to the next slide where you'll see these remarkable 2 trials that have taken place this year. The first of those, a MAPS phase 3 part 1 trial that was published recently in Nature Medicine Journal, where 67% of patients immediately went into remission after just 3 MDMA sessions with a short course of psychotherapy. 88% of the patients experienced clinically meaningful reduction in symptoms, and they are expecting that those remission rates on that trial could get to 80% with further integration with those patients. And part 2 of that trial is now taking place. And as I mentioned earlier, MDMA is expected to be prescribed within the next 18 months in the US, and Australia will follow suit in following that prescription. Furthermore, this really important trial at Imperial College, which was published in the New England Journal earlier this year, led by Robin Carhart-Harris and also with Professor David Nutt, in which they directly compared 2 doses of psilocybin with a daily dose of escitalopram, a leading SSRI antidepressant, that was taken daily for 6 weeks. Both groups had a short course of psychotherapy, and at the end of the trial, twice as many people in the psilocybin group had gone into remission as the antidepressant group. The psilocybin had quicker effects and had less side effects and less suicidal ideation. We'll go to the next slide. Thank you, Ellie. And we're just going through this pretty fast so that we leave as much time as we can for questions. So do pop your questions into the chat box, and also we'll have the opportunity for you to raise your hand and speak, because we do love a bit more interaction in these sessions as well. So currently these medicines are being trialled also for dementia, anorexia and other eating disorders, a range of addictions, stroke, starting to be looked at for schizophrenia, autism, spectrum disorder, also for some physical conditions such as weight loss and cluster headaches and fibromyalgia as well. And of course, obsessive compulsive disorder. We're also seeing these medicines now becoming available through compassionate and expanded access schemes around the world, including in Australia, where over 40 approvals have been granted to psychiatrists and specialist physicians to treat patients on a case-by-case basis who are treatment resistant. So those approvals have been granted federally, but at a state basis, they're being blocked because the states are blocking the medicines from coming into the state because they're still viewing them as recreational substances instead of medicines. This is why the rescheduling of the medicines is important, because it immediately recognises the medicines as controlled medicines. Of course, they should never have been scheduled on Schedule 9, but that's a whole other story. Furthermore, the Australian government is about to announce $15 million worth of grants for novel research in this field, and there are many trials emerging all over Australia, as well as many startup companies as well. We're also seeing these medicines legalised in Oregon and a number of other states. In Canada, it's being legalised to treat patients not only with end-of-life conditions, but also with post-traumatic stress disorder. Next slide, thanks, Ellie. I must be having Wi-Fi issues where I am, I think. I can't see that slide. Which one is it, Ellie?
Okay, it's just going through all the institutions.
Okay.
And the centers of excellence.
Yeah, fantastic. Yeah, so you can see, really the leading universities in the world have advanced R&D, and we'll go to the next slide. We'll just flick through the rest of these really quickly. You just keep passing through. Is this now the centers of excellence, or is it
No, we're on to the history, just a brief snapshot of the history.
Fantastic. The history, fantastic. So, these medicines have been with us since the beginning of human civilization. In fact, many people say from before human civilization. And they appear in the ancient archaeology of Greece and Rome, in indigenous cultures, religious communities. We have the ayahuasca churches in the 50s and 60s. Over 40,000 patients took part in therapeutic treatments in clinically controlled environments. And these medicines and treatments were considered the next big thing in psychiatry. Stan Grof, a leading psychiatrist, said that psychedelics would be for psychiatry what the microscope is for biology and medicine, or the telescope is for astronomy. Next slide. So sadly, what happened is Nixon came along with his war on drugs, This, of course, was not based on anything to do with science. This was an entirely political war on drugs to get people to join the Vietnam War movement. And sadly, there was a lot of people, yes, there was Peter's in the room. There were a lot of people in the anti-Vietnam War movement, and Nixon wanted them, going along to the war. So he criminalized the leaders of these movements. And that's what led to the war on drugs. That's what led to all research funding effectively pretty much stopping in this field. And David Nutt, who's one of our ambassadors, describes this as the worst censorship of research and medical treatment in the history of humanity. So if we go to the next slide, you can see that we have this lost 50 years. This 50 years where we've had this major spike in depression, in disconnection, where people feel very socially isolated, and we've had an increasing spike in mental illnesses. You can see there that there was literally very little research in this field at all, and now this massive renaissance. And you can see there a number of the trials taking place, and we'll go to the next slide. And of course there's this, and we'll keep going through this, this massive burgeoning of interest also from the for-profit sector, who are seeing a $1 trillion market opportunity, because of course mental illness is a wicked problem, and the for-profit sector always likes to get involved in wicked problems and capitalise on those problems. And then our strategy really is to build the ecosystem. So just going through that very briefly, we have 4 strategic pillars. The first is awareness and knowledge building. That's where these webinars come in. So we have a range of educational events. And if any of you are out there and want us to present to your clinics, your hospitals, any of your businesses or other groups, please let us know. We just had a wonderful International Medical Summit. I think a number of you attended, featuring many of the leading researchers and doctors in the world in this field. We also have regional and state chapters all over Australia, and we really encourage you to get involved in those. We have wonderful people in those chapters. It's a great way to learn more and to make sure that your local community really gets on board with these treatments. We have our certificate in psychedelic-assisted therapies, which we showed the video of at the start, which Tra-ill is one of the wonderful course directors of. And Tra-ill and Nigel are also running Fundamentals of Psychedelic-Assisted Therapy, which is a wonderful 4-part online course. And there's going to be some wonderful other courses launched as well for 2022. And I'm sure Tra-ill will be happy to talk further about those in the Q&A. We also recently launched a Neuromedicine's Discovery Centre. Well, Monash did, but on the back of the work that we've done with them, which we're thrilled to see in place for novel research. And we're also focusing, of course, on the preferred legal and ethical frameworks. We'll be resubmitting to the TGA, but as well, we're looking at clinical rollouts. We have a psychological support service. We're also looking at the manufacturing of the medicines. Next slide, thanks, Ellie. And we're just going to, in fact, I'll just get you to flick through these super quickly, because my Wi-Fi is so bad that I'm worried that it'll just get stuck. And then we can just go to the Q&A.
We're just here how you can help.
Yeah, how you can help. So, you know, Tim Ferriss there talks about his support of the space and says that this space is one of the most important spaces in which we can donate some money, because we can effectively help millions of people who are suffering, and they're suffering avoidably in many places. So, if you just go back to the how you can help slide for one more moment, Ellie, that'd be wonderful. So there's many ways that you can help by speaking to your local MPs, speaking to other medical practitioners, donating to Mind Medicine Australia, we're a charity, talking to everyone that you possibly can about this information, looking at our Learn section, attending our events, and so on. We do have a wonderful Learn section on our website, and there's lots of resources there as well. If you're a student, anything like that, or involved with universities, we have some wonderful slides for universities as well. just flick through the rest. I think Ellie's already done that, but you can see about our chapters and fundamentals and so on. I think we'll now take and stop sharing, and we're going to go to the Q&A. So that will be marvelous. Thank you all for your attention, and we're going to go to the Q&A. And Tra-ill, if we have you picked out some questions there that you'd really like to start by answering? Because I'm conscious that you haven't spoken yet, and we want to hear from you.
That's okay. You guys can just figure out the questions. I don't mind. That's fine.
No. So we'll just come to you with the questions with Ellie, there's a question here about the name of that paper and the doctor. Was that the Carl Friston paper I think someone was asking about?
Carl Friston, Friston.
Great.
Rebus,
Fantastic.
Rebus. Just Google that.
Okay,
Yeah.
and does someone have the link to the, oh yeah, we've got that one as well. In terms of the question here that, by the way, for those of you that want to put up your hands, yeah, let's answer a couple of those before we go to some of the others in the chat. So we'll go to Yanis and Ivana first. If we could unmute them, Ilan, would you be able to unmute Yanis and Ivana?
Yes, I'm doing.
Hopefully Ilan is going to do that. Okay, thank
They
you.
can do it themselves now. It's much easier.
Okay, all right. Don't all unmute yourselves at once in case your dogs are barking. But we'll go to Yanis.
Testing
Yanis,
one.
yes, we can hear you. Thank you.
Awesome. Thank you for the presentation. I have a bit of a clinical and technical question that I haven't seen discussed really in the literature. And I guess a lot of psychedelic therapies in trials are compared to antidepressants, which makes sense. But I wonder if you have any clinical thoughts on the similarities with, say, the electrotherapies like magnetic therapy or ECT. And I guess that's a weird comparison, but I was just talking at work today on the wards around ECT, and there's actually a lot of similarities. I mean, there's a single exposure with like a reset period, and the dose is quite staggered. There's some fMRI evidence showing that both transcranial magnetic stimulation and ECT target large-scale neural networks in a very similar way, targeting hubs of the default mode network. Other fMRI studies, just quickly, I won't rattle on, is showing that there's this 5-day enhanced network connectivity, both in psychedelics and in the 5 to 7 days after ECT. So look, it's a bit of a weird comparison, but they seem to be targeting large-scale neural networks in different ways. I just wonder whether that would be a good investigation question, whether maybe we should be looking at integration with ECT, or whether the dialogue should be comparing those two on a mechanism basis. I hope that made sense.
Yeah, look, I mean, I can have a go at that and you can respond as well, Ellie. I mean, I guess my first response there, Yanis, is that your description there is really talking about, physical interventions. But one of the most important things to remember about psychedelics, as Ellie said earlier, is that their success is really contingent on the quality of the experience. And that's something that I don't think is quite the same in deep cranial stimulation or any of these other kind of modalities you're describing. There is a fundamental difference. The interesting point that you raised, and I think this is the fascinating thing about your question, is you're really describing, in both cases, disruptions to brain which correspond or create, disruptions and changes in mind. And that perhaps is the point of similarity, but I think there are some fundamental differences, particularly around what we might want to call, the transcendent dimensions of experience, which have a quality of recontextualizing people's experience in psychedelics, which I think is missing from some of the more bottom-up modalities you're describing there. So I think it's a very interesting point, but I think there are some essential differences. Ellie, do you want to add to that?
Yeah, I will just reinforce what you said, that, you come out of ECT. I mean, ECT can be a miracle cure for people. I've seen people that are psychotically depressed and within a few weeks they're walking and they're talking. but it's not the experience that has helped them. It's something that no one understands what it is, but something, you know, it's something about neural networks in the brain. No one knows what it is. Alternatively, you have a psychedelic and there are obviously brain correlates of the experience, but it's the experience. It's the person has, like, in other words, like you would speak to a person that's had psychedelics, they know why they've gotten better. They can tell you, it's because I had this experience and I've realized that, you know, I saw the world this way and I understood myself this way and I blamed myself for this. And, you know, and now I've realized it wasn't me and I can connect to people again, you know, which is really a therapeutic modality. So, so there are similarities between ECT and TMS on the one hand and psychedelics, but my experience would tell me that the differences are more stark than the similarities, actually.
I agree. Great.
And it's interesting. Thank you, Yanis. And Yanis, it's also interesting, you know, to note that for many patients, they do describe these experiences with psychedelics as one of the most meaningful experiences in their lives. And that sort of goes to what Tra-ill and Ellie have been talking about. So it's more than the actual treatment or the medicine itself. It's the whole combination of everything together. Then we've got a question here from, I might just flick between the questions from the chat and the questions. So feel free to put up your hands, ladies and gentlemen, if you'd like. We're going to come back to Michaela's question. Michaela, we will answer your question, but we'll just leave it for just ask some of the more technical questions first. Which venues will likely be approved for trained practitioners to guide a series of sessions? Will centres need on-staff MDs, pending a prescription in the coming years, of course? That is the prescription linked to a therapy centre, or can a patient seek their own practitioner by reputation, etc.? Would you two gentlemen like to just, one of you comment on that just briefly, Tra-ill maybe?
Yeah, well, I mean, I think there's a few things to say about it. First of all, you know, we don't exactly know the answer to that, obviously, given the space. But what I would imagine is that these medications will be tightly controlled within, like, the hospital or centre in where they're being administered, and that would be the model that would be followed. I can't imagine a context or any kind of space really where the medicines would be prescribed and given to patients or anything like that to take home. But you know, I think in terms of our work, we're proposing an interdisciplinary team, which would involve medical specialist, psychotherapist, and support person. And those multidisciplinary teams obviously would need to work in a centralized location. Do you want to add to that, Ellie? Or
just to emphasize, I like, you know, that it's going to be multidisciplinary, which is great, because, you know, at the moment different specialties and professions tend to be a bit siloed, and it looks like it's going to be a nice nice teamwork for a change.
And I mean, that was one of the wonderful things, I think, seeing your intake of the certificate, was just seeing all the different disciplines coming together with the patient at the centre. And many of the...
That's right, Tania. And I think just to kind of emphasise that's not an ideological point, that's actually a clinically relevant point, because in a medicine session, people are so sensitized that if there are kind of hierarchies of power or any of those type of things, they actually do get picked up. And so what we're trying to do is horizontalize these relationships, you know, in the clinical space to give the best outcomes to patients.
So great to have that more flat structure. There's a question here from Samson. How do you locate and get involved in local chapters? Ilana, if you could put that into the chat, the link to the chapters. We have about 30 chapters around Australia. We'd love to welcome you to that. Tra-ill, you might be able to answer this question from Samson. Can I do the CPAC course if I've completed a diploma of mental health? Can you answer that question?
Yes, you can do the course. However, the level we have a number of different levels, as I just stated. So we have a kind of prescription style acknowledgement, we have the therapeutic and the support, and it would depend on the total kind of quality of your experience, but you could definitely do the course if you have a specialist qualification in mental health.
Thanks, Tra-ill. And Helen, would you like to ask your question now? I think you can unmute yourself. Oh, you just changed. You've changed your hair color. Helen, can you hear me okay? Sorry. You're still muted.
Sorry, I can hear,
Okay.
but I was in the chat window and trying to get back. Sorry, everyone.
Okay.
Yeah, I probably have questions that a lot of other people are thinking of. I also wanted to mention, in case there are those who haven't heard of the book by Michael Pollan, I think he's American, and it is definitely an American book, but he goes through the entire history of the research, why it got shut down, who was involved, right up to today's research. And he's also a very interesting character because he takes different types of these chemicals himself and reports back what he experienced. And his book is called How to Change Your Mind. So you guys probably are aware of it, but others might want to know. I was wondering if the course has any prerequisites. Do you need to be a therapist is what I'm really asking.
Yes, so you need to have a professional training in the areas that we just stipulated.
Sure.
So it is most of our cohort is comprised of psychologists, psychiatrists, GPs, palliative care doctors, psychotherapists, counsellors, with some allied health professionals, including mental health nurses, chiropractors, physiotherapists.
Oh, chiropractors. Well, I'll let my chiropractor know. That's great.
So,
paramedics too.
But as I said, you know, we have kind of categories of stipulation for what we're endorsing people then to be involved in what level.
Yeah. Oh, well, I imagine it's designed with a lot of sort of assumed knowledge there. So last night myself, I just want to know, okay, it's not for me. I need to go ahead and get my therapeutic training first. Which fine, because now that there will be very soon, I believe, thanks to the work being done by this group, there will be access to something that actually works. Having someone who suffered for many years and know a lot of friends who also suffered and are still stuck because there is nothing that's worked for them. Whether it's drug talking or electrotherapy, everything is basically added to, you know, you're never going to get healing kind of thinking, which is very sad. Also, I am a member of the relatively small but very vigorous and active political group called the Australian Progressives. And there are many people within the organisation that are very keen on this kind of thing being available across Australia. So I put in the chat my contact details by email. If I could have maybe a guest speaker, a presentation I can share, any information, because we have branches across Australia in the state level as well as federal. So it'd be really, really great to just forward the game and share that knowledge with some more people. Thank you. I think that's all of my questions because some of them were answered. Thank you.
Thanks, Helen. We do indeed present to clinics and hospitals, but also political parties and others. So we will email you. And, you know, if it's valuable to have Tra-ill or Ellie or whoever you would like to present, I'm sure we can arrange that for you and for anyone else on here as well. Yeah. There's a question here, I'll refer to you gentlemen, which is, I know that MDMA can have pretty bad come down effects. So I'm wondering if there are any guidelines as to when it's appropriate to recommend MDMA and when it could be even more dangerous for patients with suicidal ideation, for example.
Yeah, so I mean, that's an interesting point. It's a common misnomer, actually. Obviously, when you think about MDMA, people often think of ecstasy. They think about Suicide Tuesday. They think about all those things. There's a few things to say about that. First of all, the quality of the substance that's being ingested often is cut with lots of other chemicals. But number two, it's also these people go out, stay out all night, drink alcohol, dance furiously. They do all these things. Don't get any sleep, and you know the consequence is that they don't feel very good afterwards. in clinical spaces, such as the clinical spaces adopted by MAPS, this is not seen as an event. Like it doesn't happen. We don't have these problems. There are no suicide Tuesdays after the treatment session. So it's an interesting point, and I'm glad that someone's raised it, because it is a common misnomer that people kind of confuse the clinical space with the recreational issues.
There's a question here, Ali, about how to treat sex addiction. Now, I don't know if that's a general question or whether they mean through psychedelics, but would you like to answer that one? Or Tra-ill?
It's all Ellie,
Yeah.
that one.
I might connect it to the subsequent question, which is, if a patient has multiple issues such as OCD and PTSD, do you anticipate a catch-all therapy session, or would each issue need to be fixed separately? I think it really depends. I mean, I don't think anyone has the answer to that yet. We will know that in the coming years, but it really comes down to how you view our diagnostic classification system. If you have a view that our diagnostic classification system represents valid diagnostic entities that are disconnected from each other and separate entities, then you might argue, well, yeah, you need to address them separately. If you're like me and the people I hang out with, and you tend to see the diagnostic categories as potentially useful for research, but they're not actually valid categories, and potentially they represent underlying issues. I can speak with some authority with addictions. Certainly, I've treated thousands of people with addictions. I know for certain that addictions are outgrowths of unresolved emotional issues and trauma and emotional scars, etc. So some people in the field, including myself and the people I tend to hang out with, view psychedelics, the mechanism of action of psychedelics in a transdiagnostic framework. It's transdiagnostic because it works on the issues that underlie, fuel, and predispose us to mental health issues. So my opinion is that you would treat a sex addiction in a similar way that you would treat OCD and PTSD, which is really trying to work through what's fueling the underlying, what's fueling the symptoms, what's underlying it. Certainly that's how I treat addictions, all types of addictions. And my impression is that that's how psychedelics will work. Even though the research needs to be done with DSM diagnoses, that ultimately will be a transdiagnostic approach to mental illnesses. I hope that made a bit of sense.
Thank you, Ali. I've got a question here. Has there been research into the effectiveness of active integration with different activities, e.g. breathwork, dance, music therapy, and other new modalities of emotional release and modulation? Tra-ill, would you like to start with that one?
Well, I'm not aware of kind of specified approaches around those particular clinical approaches or methodologies, but I think it's important to say that what we're actually after is something less partialized than what we're describing there. What we want is a clinical model which is able to offer individuals, a treatment which meets their needs. And so by that, there may be a time where somatic work is appropriate, where some variation of parts work is required. All of those things are available. It is a broad church approach that we're trying to advocate essentially. But what I would say is that there are a series of common factors that run through all of that, which we're very interested in. In particular, we're very interested in the role of metacognitive processes. And, to use the kind of transpersonal parlance here, we might say on the stabilization of the view that's achieved in these experiences. And we will use whatever models or approaches that are likely to do that for an individual patient. But I don't think there is any one particular way. And I think common factors research has been pointing to that for a long time. And this actually is something we have to integrate into our understanding.
Do you want to add anything to that, Ali, or otherwise I'll keep going through the questions. There's a question here from Matt. From what I understand, multidisciplinary clinics can tend to be on the expensive side. You've mentioned you're wanting this treatment to be available to everyone. How would this be accomplished? I'll start off just briefly by answering that. Firstly, there's been an enormous amount of research done, economic modelling work done in the US, and some research that came out in Scientific American, which showed that for patients with PTSD through MDMA-assisted therapy, the potential cost savings per patient would be well in excess of $100,000 per patient. So the actual cost savings on these treatments, while there's an initial higher upfront cost, with these treatments, the fact is, if a person can get well after 2 to 3 medicinal treatments with a short course of psychotherapy and be well and leading meaningful lives, that actually not only means a hell of a lot less suffering for that person and their families and their caretakers, but it also means a lot less costs on the system. Furthermore, Mind Medicine Australia is committed to access, and so we do plan to set up a fund to help people who are less fortunate to be able to access these treatments as well. But did you guys want to add anything to that particular point?
Yeah, I think that's excellent, Tania, those points you raised. I guess in terms of the clinical modelling, there are a number of attempts to try and address that problem. For example, at Johns Hopkins, they're looking at having multiple sessions run simultaneously in individual rooms with shared music, individual therapists, but then that integration occurring within a group format. There's a number of different approaches, and really we won't have the full answer to that until we move forward. But what we don't want to see is people given a medicine and locked into a room for the next 6 hours. I mean, it's really, really important that it's held and they're treated in the right kind of way. And, the modelling on this shows that even when we approach it in the way we're describing, there's still a huge cost benefit to it. So I think that's important.
Thank you. So there's a couple of questions here that relate to the recent TGA decision, and I'm going to speak about both of those together. Except for, well, before I do, there's just another one that's come up, which is on the clinical use again. Is the focus headed towards one-on-one sessions, or is both one-on-one and group? Oh, well, I think you've just sort of covered that, Tra-ill, about the one-on-one and the group.
Yes, that's right.
Did you? Yep. Okay.
Yeah, that's right. Okay. So, I mean, I think, for example, with the MDMA work, there is increased exploration around the value of like dose sessions in group. For some people, and you can imagine, for example, soldiers and things like that, it may be really applicable in those kind of settings and contexts. And so I think it's individual therapy and group therapy are both amenable to psychedelic work.
And couples work as well.
Couples work. I mean, I think all therapy is amenable to it in some shape or form.
Look, I've got Peter here as well, because he was just going to help and just give some background on the TGA decision. So we might start with Bektu's question, and then we'll go to Michaela's question. So you want to start with Bektu's question first, Peter?
Yeah, so the question is, with such therapeutic potential, why is the TGA so hesitant to downschedule these medications to Schedule 8 drugs? I think simply because they've been illegal for 50 years following the UN Convention, and there is a lot of political concern about particularly the recreational use of MDMA and the confusion between medical use and recreational use. And the TGA, it may well be our top therapeutic regulator, but it lives and breathes in a political environment. When you look at the reasoning of the TGA, a lot of it doesn't make sense. So, for example, they say that the UN Convention wouldn't allow rescheduling. Well, actually, that's not right, because there's a specific exemption in the UN Convention that allows it. They make a number of other comments in their final decision, which actually don't stand up to scrutiny, like, for example, diversion risks, that doctors and pharmacists would divert medical grade psilocybin and MDMA into the recreational area. Now, when you think about that, it's pretty daft because medical grade MDMA and psilocybin is very expensive. Psilocybin itself, as we all know, is actually very cheap. You just go into a field and pick the mushrooms, or you have one of your mates do that. MDMA on the black market is relatively cheap. So why a doctor or pharmacist would risk their practicing certificates to divert into the recreational space is completely beyond me. And Schedule 8 medicines have controls which doctors and pharmacists are well used to using in terms of accountability. So it's hard to know what actually goes on within the TGA, other than to say that we think the evidence is so strong, we're going straight back with another application to really tease out these issues, and hopefully this time around we'll be successful.
And we do encourage you when it goes out to public consultation to please to put in your supporting letters and so on. There's a question here as well from Michaela. I'm wondering what the future may look like, considering the TGA has denied the application for therapeutic treatments. That's certainly not going to stop us, as Peter's mentioned, from making another application. But furthermore, of course, there's many other ways that therapists, like many of you on this webinar, will be able to participate. We hope to certainly start seeing some treatments getting through the special access schemes. As we mentioned, that there have been federal approvals. We hope to get some state ones coming through. As well, we have a number of trials that are starting to take place that will involve therapists, observational trials as well. Did you want to further comment on that question as well?
Well, just to say that we will continue to make representations to state governments, because they're the problem at the moment in the absence of rescheduling. At the same time, we are involved in what are some pretty large trials. So, just wait and watch this space. We're also seeing a challenge in Victoria for the Victorian government, which failed to approve a special access scheme, approved doctor and patient accessing these therapies. So there's a lot happening. We're just going to keep pushing until in controlled environments with proper protocols, doctors and patients have the option of using these therapies, as I say, with the right controls in place.
There's a question here from Fiona. Has there been any effect of the psychedelics noted on people's dream life after the sessions, which also reflect an accessing of unconscious content? Carl, did you want to start with that one?
Yeah, again, I mean, I'm not sure of any particular research into that, but colloquially, obviously, people often describe an increased vividness in their dream life post-psychedelic session. And, Freud was right, that dreams are the royal road to the unconscious. Well, psychedelics may well be an important component to increasing our understanding of that space.
Thank you. Ellie, did you want to add to that one at all as well?
I put in a note that maybe Fiona would be interested in this book, which talks about that specifically. So it's about Jung and psychedelics and dreams and interesting things like that. I wrote the title. I don't have any shares in that book. I just think it's a good book.
There's a question here from Craig. How would I find access to trials or even doctors to help me get some into these sessions? I've mentioned to my GP about MDMA therapy, and she did everything but laugh at me. Well, firstly, Craig, if you could introduce your GP to us, we'd be more than happy to inform her or him about these treatments, and also to our Learn section on our website. I find that, every time I go to a GP, that they're extremely interested once they get to understand a bit more about the data and science. And a GP laughing is really just an example of, unfortunately, the prejudice and stigma that's still attached to these treatments. And we just have to make sure that that is, blown out as much as we can, so that people are focusing on the data and science. You say you've contacted a few of the therapists on the Mind Medicine website with no reply. Well, I'm really sorry about that, and I don't know why that's happening. If you send us an email, Craig, I'll forward it to Tra-ill, if that's all right, Tra-ill. And we will make sure that you do get some support through our psychological support service. And no, you're not a crazy person emailing unsolicited questions. We absolutely honour and respect you, and we want to help as much as we can. So please send an email. I'm Tania, Tania, at mindmedicineaustralia.org. Send it directly to me. I'll send it to Tra-ill, and we will do whatever we can to help. Cameron, you asked, is the TGA operating from solely a risk assessment point of view? Peter, is the TGA operating from solely a risk assessment point of view? Would you agree with that one?
Look, I think it's very much what I said before. I mean, the TGA does operate within a political environment, and it's got a range of stakeholders. And, you know, yes, risk has to be central, but the reality is, in all the trials that have taken place, it's become quite clear that if these medicines are used properly in medically controlled environments, they can be used very safely. So from a pure risk perspective, which is safety, it's very hard to see what the issue really is, other than making sure that the proper protocols are put in place, the patients are properly screened, and all the other things that will be uppermost in the minds of psychiatrists like Ellie.
I might just add that it's my understanding of the TGA's decision that the difference between Schedule 8 and Schedule 9 is based on whether the medication has some therapeutic value. So Schedule 9 is no therapeutic value. Schedule 8 is some therapeutic value. Both Schedule 9 and 8 include medicines and compounds that have some dangers of addiction. So that's what Schedule 8 is. Schedule 8 is medicines that can be addictive, but there is some therapeutic value. Schedule 9 is there is no therapeutic value. So the TGA forced itself into a position where it had to argue that there is no therapeutic value for MDMA and psilocybin. How do you do that if there are studies that show that they do have therapeutic value? So one thing, for example, that the TGA said, and this is in their statement, everyone can look it up, it's publicly available. They said that MDMA has been trialled in clinical trials, but that's clinical trials. We don't know it's going to work in the real world. And so, you know, with arguments like that, they can then say, well, there's no therapeutic value because it's only in clinical trials that MDMA has worked. You know, yes. and these are the sort of backflips and mental acrobatics that I think the TGA forced itself into because I think according to their own guidelines, there's no doubt in my mind that it should be in Schedule 8. There is some therapeutic value to these substances. So there's, but they had to argue that there's no therapeutic value.
Which is even more bizarre when you consider that they're granting SASB, special access fee approvals, which surely does absolutely reinforce the fact that not only are they safe, but they do have a therapeutic value. So, yes, very interesting conundrum. Sorry.
Hence the decision to lodge another rescheduling application and really tease out these issues in detail.
Yes, we do have Alex, a great working relationship with MAPS. Tra-ill and Nigel Denning, he's co-director of CPAD and Mind Medicine Institute, have just done the MAPS training. And Rick Doblin is one of our ambassadors. Back to, you say you're about to commence your GP training, hoping for some progress on this. Yes, we hope you don't have to keep dishing out SSRIs all the time. We certainly hope that. Then we have, and we're just about to conclude, I just noticed a couple more questions come in. Is it currently legal to prescribe any psychedelic? Well, yes, indeed, ketamine and strangely enough, ibogaine in Schedule 4 as well. Ibogaine Schedule 4, yeah. Very weird. Very weird. So indeed they are. Sonia, if you want to reach out to us and need any more order information, let us know. My email address, Tania, Tania @ mindmedicineaustralia.org for you again, Craig. or else write to our general box and ask to be sent to me. Yes, the whole situation is absurd. It is outrageous. I'm just looking at these comments. Yes, I love that doctors prescribe opioids for tonsils operations on teens. Yes, the vaccines were approved within a matter of days. These have been around for thousands of years. It is a strange world we're living in. And thank you to all of you, really, the alcohol and drug counsellors on this call, your psychiatrists, psychologists. Back to, I think, a big reason for the medical community not being very supportive of these therapies, that we cannot legally experience the benefits as they are illegal. We agree with you, Beck, too. We risk our accreditation with APRA if we choose to explore with them. Any tips on getting clinicians to experience these states? Well, that's an extremely good question.
Just watch the space.
Watch this space. We will be making an announcement on this shortly. Also, Peter and I met with the Medical Board of Australia yesterday, with the chair and other senior people. We particularly met with them because there'd been some comments from therapists during our summit that suggested that therapists were afraid of speaking publicly about these treatments in a positive way to media or others. The chair of the medical board and the other people on the call who run APRA and notification said that they're obliged to always follow up notifications, but at no point would they ever penalise a therapist for speaking positively about these treatments, either to the media or to their other fellow colleagues or in any forum whatsoever. So please do not be afraid to talk about these treatments. If you do happen to have a problem and you are investigated, please reach out to us straight away, because they assured us that no one would be investigated, though notifications could occur for any reason and we can't really prevent them occurring.
With the caveat, obviously you make the point that you're only in favour of these things in a regulatory controlled and approved environment.
Yeah. Helen, you say the influence of the pharmaceutical industry. Yes, we certainly understand the influence of the industry. Brad, you say you could challenge the TGA decision via the Administrative Appeals Tribunal and then to the Federal Court. Is that true or not, Peter?
I'll tell you the problem, and this is on the advice of senior counsel, and that is that the decision of the delegate has the force of legislation. So just in the same way as you can't take Parliament to court for passing legislation, the delegate's decision is given the same standing. And by the way, the whole process is incredibly oblique. We still have no idea who the delegate is, who made the decision, or what qualifications the delegate had to make that decision.
With that, I think we'd just like to say, a huge thank you to all of you for joining us for this webinar. It's very close to Christmas. We're hesitant about running a webinar this close to Christmas, but the interest in this field has not stopped really for the last 3 years. Peter and I are exhausted. We're looking forward to having a little break over Christmas. But I do want to just acknowledge Tra-ill and Ellie, both of whom have been incredibly supportive to Mind Medicine Australia, both of whom have an enormous amount of knowledge, and we really just respect their wisdom enormously, their compassion as practitioners and just wise people that are part of our wonderful Mind Medicine Australia family. And we want to thank them with so much love and gratitude for their support for everything that we're doing. And that we really just very much look forward to welcoming all of you. We have a wonderful group of people working with Mind Medicine Australia. We welcome you to join our family in any way that you want, or support us in any way that you can this Christmas and beyond. And I promise you that we will never give up this fight that we're on.
And it will happen. It's just a question of time.
It will happen, and we all just need to fight the good fight and keep rowing our boats in the same direction together. So thank you for all that you do. For those of you that are clinicians on this call, We know it's tough. We know you need more tools in your toolbox, and we just acknowledge each of you for what you do in the world. And for those of you that are patients on this call, please don't give up hope. Please don't. It's just a matter of time. It's not a matter of if, it's just a matter of when. And we will do everything we can to make this happen as soon as possible. And to those of you that are researchers on this call, we acknowledge your wonderful research, and we say that research and clinical use can happen in tandem together. It doesn't have to be one or the other. So we acknowledge all the wonderful research, but please don't let that stop those who are suffering terribly from having access to these treatments. So with that, I just want to say festive, happy holidays. May 2022 be a better year than 2021. I think we probably all wish that. And may light, bring your light into this world so that we can continue to shine truth and transparency wherever possible into these processes, so that we can actually start to heal the immense suffering in our community. So with that, I just want to say thank you to you all. I also want to thank you, Ilan, our wonderful operations manager, for his incredible support for our webinar series. Thank you so much, Ilan. And we will be sending out a thank you note tomorrow that has a lot of resources, has the presentation in it. This webinar will go onto our YouTube platform where you can watch it again or share it with your other colleagues. And thank you and for all your support, everyone.